Hi, I'm Mohammed Jahanzeb. I'm a medical oncologist in Boca Raton, Florida. I focus on lung cancer and breast cancer, and I work with Florida Precision Oncology, a division of 21st Century Oncology.
Hi, I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C.
I'm Michael Lanuti. I'm a thoracic surgeon at Mass General Hospital. I'm the director of thoracic oncology in our division of thoracic surgery, and I'm an associate professor at Harvard Medical School.
Hi, I'm Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I am chief of thoracic radiation oncology and stereotactic body radiotherapy and director of clinical trials.
Hi, I'm Michelle Ginsberg. I'm a radiologist and I'm director of cardiothoracic imaging and vice chair for education at Memorial Sloan Kettering Cancer Center in New York City.
This is a 91-year-old lifelong non-smoker presenting for evaluation of incidental lung nodules found during evaluation of a fall. CT of the chest in April of 29 showed multiple bilateral subsolid nodules, and he'll explain what subsolid is. The largest measuring 2.4 centimeters in the right lung anterior segment with a 12 millimeter solid component. Other lesions included a 13 millimeter right upper lobe subsolid nodule with a 4 millimeter solid component and 11 millimeter left upper lobe ground glass opacity with 6 millimeter solid component. I'll let Dr. Lanuti take it from here.
She had a sort of a cervical assessment with CT neck that demonstrated that spot in her lung on the upward images of the chest, and hence she had some delay in sort of follow-up, and then I saw her. As I mentioned, she's very robust. She's still was working up until a few months ago, and with a performance status of about 1. She had no other significant medical problems except for some back pain and leg pain, which was felt to be neurogenic in origin. I place her pulmonary function test here just for all of us to have, in that she had a relatively preserved function and capacity for 91 years old. Other pertinent history was hypertension. She does have a history of renal insufficiency, but I must say her baseline creatinine, she's a small person, was about 1.5 with a GFR glomerular filtration rate of 48, asthma and cataracts. She was a non-smoker, and as I mentioned, she was an illustrator for medicine. And in the family, there was no history of lung cancer. These are the selected images that I'll have Dr. Ginsberg just take a quick look at. There are more slices beyond this.
On these images is a 2.4 centimeter subsolid, or also known as part solid nodule. And what that refers to is a nodule that has solid, like dense component, and also ground glass component, which is sort of a hazier appearance. And you see those components on these images. The solid component is generally associated with the invasive component of a tumor. On the corresponding PET CT, we see that it is FDG avid. And these are images that are obtained in on the left-hand side in a coronal view, meaning from the front of the patient going backwards towards the spine. And we see 2 additional small nodules in the right upper lobe. And the image on the right is an axial, which is sort of slicing through a patient from top to bottom. And in that image, we see another small nodule, which is solid. Possibly has a little bit of a ground glass component, but once you have, as I mentioned, solid component, that's the invasive component. On the corresponding PET CT, we don't see uptake, but that does not mean that these are not malignant lesions. It just means that they may be beyond the resolution of the PET CT to show up. So that should not give a false sense of security.
Could there also be a difference in metabolism sometimes, because PET is in a way sugar eating activity of the cells, that if the cells are not eating enough sugar, or in other words, not metabolically very active, that you could miss
Correct.
that?
Correct. So ground glass nodules, which don't have the solid component and could still be malignant, generally don't show this uptake. And different tumors, as you mentioned, will have different uptakes.
Great. So let's continue with the case, Dr. Lanuti.
So to clarify, which is also important, is that there was no hypermetabolism in the mediastinum on the PET scan, in that we use PET scan to assess the pulmonary nodules and the target index lesion, but we also use it to assess the intrathoracic evidence of lymph node spread. And in this case, they were negative in the hilum and negative in the mediastinum. And lastly, we use PET scan to assess extrathoracic suspicious disease. And in that, the PET scan is a scan that's done from head to typically thighs or knees, assessing the entire body. So the considerations here are, what do you do with this dominant lesion that has that solid component in the right upper lobe? And do you need to get a biopsy? And what are our options? I guess we can present this to the panel, or I could tell you what we did.
No, let's keep it fun by first presenting it to the panel. So let me call on Dr. Robinson. Can you tell us about SBRT and who's appropriate for that intervention?
Sure. Just before I maybe talk about SBRT in general, I'll just say that for me, the biggest consideration when we're looking at a case like this is that this is somebody who falls into something we used to call multifocal BAC. If we were to get a pathology specimen, this patient would likely to have a minimally invasive adenocarcinoma. The challenge is, of course, as Dr. Lanuti very nicely elaborated, is guessing when these tumors become less indolent, less slow growing, and when they're more likely to spread either to the mediastinum or distantly. And that becomes a bit of a guessing game. There are, data from our colleagues in East Asia where they have a higher incidence of this cancer that would suggest that as the solid component gets bigger or the PET uptake becomes brighter, that the risk becomes higher. And that's relevant as we kind of talk about this moving forward. So with regard to SBRT, so SBRT is a technique. It stands for stereotactic body radiotherapy. It's also a technique that has many names. So another name for this, particularly in Europe, is SABR, stereotactic ablative body radiotherapy. It is not a machine. So despite the fact that there are machines that specialize in doing this, that have different trade names, many machines are capable of doing this. It is essentially a technique that allows precision, high-dose radiation per treatment. So we're using larger doses per day than we talked about with the last case. Previously, we talked about giving 1.8 to 2 gray of radiation per day over 5 weeks, 5 days a week. You might give 10 to 20 gray per treatment over 1 to 5 sessions for something like this. So the potency of the treatment is much higher. The doses we give are actually potentially quite damaging to healthy tissues, but the principle of the technique is that we're keeping the dose confined just to the tumor, or at least just to the tumor and a small area around it, such that damage, like a surgery in a way of speaking, is confined to that region. Now, just in general, without kind of embarking on a very long discussion of the relative benefits in general, I would just say that the potential appeal to a treatment like this would be that it is non-invasive, so it doesn't require anesthesia or coming into the hospital for a surgery, but it has its own potential downsides as well, and that is that when you look at treating multiple nodules, the body receives an accumulating dose of radiation. So for every nodule you treat, you're exposing more and more healthy lung, and those low doses of radiation, those kind of unintentional scatter doses, can add up and increase the risk of toxicity. And unlike a surgeon, we don't have the ability we have to trust the PET scan implicitly. So as we saw in that last case before, where the PET scan said everything was fine, but in fact there was lymph nodes that were hidden, they were surprise lymph nodes, for a focused radiation treatment, we don't have the ability to assess that.
So patients often throw around terms that they have heard or Googled on the internet, and they also talk about cyber knife and gamma knife. Can you
Yeah, I was
their
trying, I
benefit
was trying to dodge
differentiate?
I was trying to dodge the trademarks, but yes, that's fine. So yes, so CyberKnife is a machine that was developed many years ago before other machines were capable of doing this. That implicitly or explicitly, should I say, only does these focused radiation treatments from essentially head to toe. So it's a machine that looks like a robot that rotates around you and delivers focused radiation from many directions. It's certainly a very capable machine. However, it only does this. Many of us use our standard radiation machines called linear accelerators that rotate around the patient and can deliver treatments much faster in 5 to 7 minutes. A machine like that often takes 90 minutes or so. But without talking about the pros and cons, there's no evidence that one of those machines does a better job of delivering radiation and killing the cancer than another one.
Yeah, but some patients don't realize that there are some differences. I've seen patients drop their lung because they're going to need a fiducial for CyberKnife, which is not necessary with the other machines. Would you want to elaborate on that?
Yeah. So there's different, one of the questions we get a lot is, how are you going to make sure that you're actually treating the tumor and not some other part of me? On most, what we call C-arm linear accelerators, which are the conventional radiation machines many people see when they look on Google, we have special panels attached to them which can take x-rays and even make CT scans. So we can do a CT scan right before we deliver treatment. So we can see the tumor, align the tumor to the right place, and then deliver the treatment immediately without having to do anything to follow it. Other machines, CyberKnife and others, because they don't have that capability, often require you to insert what's called a fiducial marker. That's a little piece of metal that would allow you to see the tumor as you treat it. That in theory is nice because the machine can follow it and track it, but it does require an additional procedure. Full disclosure, that's not required for all patients, even with the CyberKnife as well. But that is a pro and con that a patient should be aware of when they're talking to their radiation doctor. They should ask about that whole process and what their capabilities are.
Excellent, thank you. So Dr. Lanuti, now you can tell us about VATS and how that compares with SBRT, and how do you make the choice? How do you determine that somebody should not have VATS and should go to Dr. Robinson?
Yeah, so that's obviously the crux of the matter. And for us, it comes down to performance of the patient and safety, and of course, adequate cardiopulmonary reserve. So those patients that have inadequate pulmonary reserve, it's quite easy for us to refer those patients to the next best treatment modality, which is clearly SBRT. We have not talked about thermoablation in this setting, but I don't want to talk about that too much, but it is something to think about, as percutaneous thermoablation is an option. So for patients who we're considering surgery versus radiation, really we favor surgery. Surgery is the standard of care for early stage lung cancer. The outcomes have been tested, tried and true. There have been attempts at comparing SBRT to surgery for operable patients, although all those trials have ended early. And for the sake of time, I would say surgery still is the preferred standard for early stage lung cancer. So in her case, good.
No, go ahead.
So this was a 91-year-old, and you'd say, geez, what is the surgical risk of someone in their almost 10th decade of life? And the risks are clearly higher. So in our surgical series and publications, when you're in your 8th, 9th, and 10th decade of life, we clearly have higher risks, be it pneumonia, arrhythmias, and poor return to function. So on this patient, on balance, she had a poor performance status that was quite remarkable. And I decided that one, could we biopsy this, or we could biopsy it if she was going to go to a non-surgical option, but she was more the mindset to take the risk of surgery. And I chose to oblige that. And the goal of surgery in this case, given the multifocal nature of her imaging, was to go after the dominant lesion, the lesion that has the solid component, the lesion that would be the greatest threat to life. And so our options are do what's called a VATS wedge resection. That is, do something less than a lobectomy, which can be achieved quite easily with low morbidity. And the downside of a wedge or something that's less than a lobe is that there's an increased risk of local recurrence in the lobe. But in someone who's 91, we would say, how many more years of life do you want? And so that comes into the equation and can come under debate. There is a higher risk of lobectomy compared to a wedge for a 91-year-old. Hence, I chose to do a sublobar approach.
And you can tell us what you found.
We did the bronchoscopy, we did that wedge resection, and then while I was in the chest, we sampled all the regional and mediastinal lymph nodes. There were 2 lesions in that wedge specimen. The dominant lesion was this 2.6 centimeter well-differentiated lipidic histotype adenocarcinoma, 60% lipidic, as you can see there. And the invasive component in the 8th staging system is the difference compared to the previous staging system where we actually measure the invasive component. So despite the large nature of the tumor at 2.6, only 1.04 was actually the invasive component, which in essence brings the stage down, if you will. And so in the 8th system, it's T1B because it's just over a centimeter of invasion, and all the regional nodes were negative. There was a second lesion in that specimen, which was a minimally invasive adenocarcinoma, about 1.3 centimeters. And you see there, the invasive component was even smaller and designated as a T1 minimally invasive N0 lesion. She did quite well. And, of course, the next question is, what do you do with the remainder of the suspicious subsolid lesions in someone who's at her age?
How would you follow those? Just with serial CTs of the chest, how frequently?
Yeah, so I would say if we took age out of the equation, I wouldn't change how we manage this. I would say someone who has subsolid lesions, if they're not changing and you already have a year of imaging under your belt, we can go with yearly imaging. If they're starting to develop a solid component, we tend to follow them more frequently. And every 6 months. If you're very worried, it could be every 3 months. But in her, I was going to probably do every 6 months for the first 2 years, and then once a year thereafter.
Great. So Dr. Levy, back to you. If she had an EGFR mutation, would you offer her osimertinib?
This is such a great case and such a complicated one. Never before is a shared decision-making more important than in a patient with multifocal adenocarcinoma, where you got to get the patient's buy-in given the competing strategies and the lack of data for some of this. What's interesting is, I agree with everything so far. I think that it gets tricky when you resect these and they reveal an EGFR mutation and you think, aha, the other nodules must also harbor EGFR mutations. But the data is a little bit conflicting on this. And in fact, some of the data suggests that there's somewhere between the order of 50 to 60% discrepancy in mutation rate from the same patient with multifocal adenocarcinoma. So I cannot be assured that even though Dr. Lunetti removed this appropriately and it harbors an EGFR mutation, that the rest of the nodules are harboring this. I think that, again, this is a shared decision making. You could certainly try and follow the nodules to see if they shrink, or you could hold off and just see the kinetics. I think it's so important to follow kinetics. And so if this were my patient, again, I'll put my nickel down. I would probably just, if the patient had an EGFR mutation and the other semi-solid nodules were just kind of there, I'd probably watch in a 91-year-old who needs to get back to medical illustrating. I certainly don't want to cause any paronychia with the osimertinib, which is rare but can happen. So I would, when in doubt, do nothing, especially for someone who's 91. So I would hold off and follow the kinetics of these other tumors and just follow them.
Excellent. I was hoping you would say that.
I'd like to echo that as well. And I would also say that this is not an uncommon situation we run into. While debating the relative merits of surgery versus SBRT is something that's quite fashionable and fun to do, the reality is at the end of the day, there's a patient behind that. And I think that I agree with Dr. Lanuti that for, in general, for medically operable patients, surgery remains the standard of care. I will say that after that surgery, however, it's relatively uncommon that as the patient gets older, if we see one of these lesions start to become more solid, that we would typically dive right into additional surgery. So they tend to then flow to our clinic, where if we were to watch this carefully, and I echo what Dr. Levy and Dr. Lanuti said, that if we see one of these lesions start to become more solid and then PET avid, it's not uncommon for us to then consider treating with SBRT at that point before we dive into considering systemic therapy. And in fact, often we'll say, well, we feel like we've gotten a diagnosis from the initial pathology. We might even consider treating empirically without an additional tissue diagnosis.
Great. One final question for Dr. Ginsberg. Since whether this scan is annual or every 6 months, you become the person who reviews it and comments on it, along with the surgeons, radiation oncologists. Medical oncologists are mostly out of the loop in these decisions, usually until it comes to systemic therapy. So it's becoming quite sophisticated how our imaging has improved over the years and how composition of these nodules are being classified or looked at from a radiographic standpoint. Can you tell us a little bit about that, the role of the radiologist in following these?
Yes, so we follow them with serial CT scans, which, because we're looking at the lung parenchyma, don't need intravenous contrast. So they're fairly easy for the patient to tolerate. And we look at thin cuts, which are the thinnest cuts you could reconstruct. Doesn't mean that the patient's getting more radiation. It's just something that it's post-processing. And we look for things as far as size and in growth, but specifically we also look for these solid components, as was mentioned. So in these thin sections, you could measure the tiny nodules. In this case, the tumor, the solid component was only 0.4 centimeters. That's very tiny. So that's what we're following with serial scans.
Great. This has been a truly enlightening discussion. I thank all of you. These were phenomenal cases, all requiring multidisciplinary input, and it's such a treat to have world-renowned experts discussing them and coming to a consensus. Thank you all.